This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026, titled Gamma Knife Radiosurgery in Pediatric Neuro-Oncology, Histology-Specific Outcomes and Age-Adapted Procedural Strategies.
This is a timely piece, Alara. We've seen a significant shift in how we approach pediatric brain tumors. For a long time, there was a lot of hesitation regarding radiosurgery in children because of the developing brain and the potential for long-term radiation-induced effects. But this paper really dives into how we can refine the technique based on the child's age and the specific pathology.
Exactly. The study looks at a large cohort and breaks down outcomes by histology, specifically looking at low-grade gliomas, craniopharyngiomas, and ependymomas, among others. But before we get into the how well it works part, let's talk about the how we do it part, because the authors emphasize age-adapted procedural strategies.
Right. In an adult, Gamma Knife is fairly straightforward. Local anesthesia, the Lexel frame, and they're good to go. But in a 4-year-old, that's a different story. The paper highlights the necessity of a multidisciplinary approach involving pediatric anesthesiology.
They really stress that for the younger age groups, essentially anyone under age 12 or those with significant anxiety, general anesthesia or deep sedation is the standard. They mention that for infants and toddlers, the physiological monitoring during the long wait times between the MRI and the actual treatment is a critical bottleneck that requires dedicated nursing.
And what about the frame itself? That's always the technical challenge in kids.
That was a key part of the age-adapted section. The authors discuss the challenge of the thin pediatric calvarium. In children under 5, the skull is often too thin or too soft for standard pin pressure. The paper suggests using a low-pressure pin placement strategy, or increasingly, the use of the thermoplastic mask-based immobilization if the clinic is equipped with the Gamma Knife Icon or Esprit systems.
I found it interesting that they still advocated for the frame in specific cases where sub-millimeter precision is non-negotiable, like a lesion right against the optic chiasm. They suggest that if a frame must be used on a very young child, we should use more pins, perhaps 6 instead of the standard 4, to distribute the pressure more evenly across the skull.
And they mention the inner table risk. You have to be extremely careful not to over-tighten because the bone can give way. Now, moving to the results, the histology-specific outcomes were really the meat of this paper. For low-grade gliomas, specifically pilocytic astrocytomas, the local control rates they reported were impressive.
They were. I believe they cited a 5-year local control rate of over 90% for LGGs. That's comparable to what we see with subtotal resection followed by observation, but with a much lower immediate morbidity if the tumor is in a deep-seated area like the thalamus or brainstem.
They did note, however, that pseudoprogression is a real phenomenon in these kids. On the 6-month follow-up MRI, the tumor might look slightly larger or show more enhancement, which can panic a resident or a parent. But the paper clarifies that in the absence of new clinical symptoms, we should stay the course and not rush into a rescue surgery.
That's a vital point for the residents listening. Don't jump the gun on a growing lesion post-GKRS unless the neurology is worsening. Now, what about craniopharyngiomas? That's always a controversial topic.
The paper categorizes GKRS for craniopharyngiomas as a highly effective adjuvant or salvage therapy. In cases where there's a small residual after a subtotal resection or a recurrence in the cavernous sinus where you don't want to go back in, GKRS showed a tumor control rate of around 80%. But, and this is a big but, the dose to the optic apparatus was strictly capped.
They used a 10 to 12 GI limit for the optic chiasm and nerves, right?
Exactly. And they noted that for children, the endocrine outcomes are actually the bigger concern. Even with precise targeting, there's a risk of growth hormone deficiency or other pituitary axes being affected over time, especially if the tumor is in the infundibular region. The study suggests long-term follow-up with a pediatric endocrinologist is mandatory.
Let's talk about ependymomas. Historically, we've been more aggressive with re-resection and proton beam or external beam radiation for these. Where does Gamma Knife fit in, according to this study?
The study was quite specific here. They don't recommend GKRS as a primary treatment for ependymoma. Instead, they see it as a focal boost for small, well-defined recurrences or residuals that are not amenable to further surgery. The outcomes there were more modest. Local control was around 60–70%, which reflects the more aggressive biology of ependymoma tumors compared to grade 1 gliomas.
It's that balance of biology versus physics. You can hit it with 20 GI, but if the biology is proliferative and infiltrative, a focal treatment like Gamma Knife has its limits. Did they mention the risk of secondary malignancies? That's always the elephant in the room when we talk about radiating children.
They did. In their cohort, the incidence of radiation-induced tumors was very low, less than 1% over the follow-up period. However, they were very clear that low risk is not zero risk. They emphasized that GKRS provides a much steeper dose fall-off than traditional radiotherapy, which reduces the integral dose to the rest of the developing brain. This is why they argue it's a preferred modality for small focal lesions.
And for the practicing surgeons out there, did the paper touch on the marginal dose for these different histologies?
Yes. For LGGs, they found that a marginal dose of 12 to 13 GI was the sweet spot. For craniopharyngiomas, they tended to stay around 11 to 12 GI to the 50% isotose line. For the more aggressive lesions, like ependymomas or even some rare germ cell tumor recurrences, they pushed closer to 15 or 16 GI, provided the surrounding critical structures allowed it.
One thing that stood out to me in the procedural strategies was the mention of the vascular complications. We don't talk about it enough, but radiating tumors near the circle of Willis in children can lead to vasculopathy, essentially a moya-moya-like syndrome.
The paper actually identified that as a histology-independent risk. If the tumor is encasing the internal carotid or the middle cerebral artery, the risk of stenosis increases. They recommend MRA or CTA monitoring in those specific cases, especially if the child was very young at the time of treatment.
That's a great clinical pearl. If you're treating a sellar or supercellar lesion, you're not just watching the tumor and the hormones, you're watching the vessels.
To wrap up the technical side, the authors also discussed fractionated radiosurgery using the mask. They suggested that for larger lesions, anything over 3 centimeters or those very close to the optic pathway, moving from a single session to 3 or 5 fractions might be the future of pediatric gamma knife. It allows for a higher total dose while sparing the healthy tissues.
It's really about the evolution of the tool. Gamma knife isn't just a one-shot device anymore. The flexibility of the newer platforms allows us to be much more age-adapted, as the title says.
Any final thoughts, Dr. Aris, for the residents who might be rotating through the gamma knife suite?
I think the takeaway from this paper is that pediatric is not just small adult. You have to account for the skull thickness, the anesthetic requirements, and the fact that these patients will hopefully live for 70 more years. The histology-specific data shows that we can be very successful, but we have to be disciplined with our dosimetry and our follow-up.
Well said. This study in child's nervous system provides a great roadmap for that discipline. It's a call for precision, not just in the radiation beam, but in our patient selection and our long-term management.
Absolutely. Thanks for joining me today, Alara. This has been an excellent deep dive.
Thank you, Dr. Aris. And to our listeners, stay tuned for our next episode where we'll discuss the latest in endovascular neurosurgery.
See you next time on the Neurosurgery Hub podcast.